Today, we are going to cover all things musculoskeletal for women going through peri and post-menopause with someone who really knows all about it, Dr. Vonda Wright. And she is a double board certified orthopedic sports surgeon who has 20 years of research, and she cares for elite athletes, executives, and high performance people. So she sees people who are injured like all the time. And I was really lucky to find her through the Feisty Menopause group. You know, I always talk about this group, in which I found through Dr. Stacy Sims and the host of the Hit Play Not Pause podcast, Selene Yeager. You know, I'm so passionate about following that podcast as well. I encourage you all to go and listen to it too. Now, all the women in this Feisty Menopause group are really incredibly inspiring, and they put out such amazing content for women making the menopause transition. And I'll include links to all of them in the show notes. Now, Dr. Wright, she cares for professional athletes of the NFL, the PGA, World Rugby, the Pittsburgh and Atlanta ballet theaters, as well as collegiate and elite masters competitors and ordinary people like us. So she has also written 5 books in the fitness and performance space, maybe even more. And she's, really these books have spurred a fitness line in 500 Dick's Sporting Goods store. And that's a brand in the US. Now, she also speaks worldwide for corporate, foundation, and family office audiences, and frequently contributes content to the US national media. And currently, Dr. Wright serves as the inaugural president and surgeon of the Legacy Houston Orthopedics Group. That's Southeast based in Lake Nona in Florida, near Orlando, in case any of you guys are near there. And she provides elite sports medicine to both athletes and active people. So she's really right up our alley as an active aging and longevity researcher too. And when she treats clients, she really takes a whole person precision approach. And she offers individual health span and longevity advising. Isn't that the coolest thing? And she also does group retreats, which I hope she'll tell us a little bit more about. And her mantra is, ideas are easy. Execution is everything. Now, for the fancy disclaimer, although Dr. Wright is a physician, she is not your physician, unless you want to join the amazing people who travel to see her in Lake Nona, Florida in the US. And all of her conversations should be considered education and not treatment. Always discuss what you've learned with your own physician. So now, without further ado, let's meet Dr. Wright. Welcome.
Thank you so much for having me. It's an honor. And it's amazing that we can do this across the globe, isn't it?
Yeah, it's great that we can touch so many people and share really valuable information that we can't get if we were just in our own little bubble. So I really appreciate you taking some time right now for us. Let's start with, so we're going to talk, really keep the menopausal, the perimenopausal, postmenopausal woman in mind. And we hear all about hot flashes and brain fog and weight gain. These are the typical symptoms, but we don't hear a lot about the effects of estrogen, the decline of that on the musculoskeletal system. So what kind of symptoms are we having in this period of life? How common are they, and why do they matter?
So I love the opportunity to talk about this because of the 34 categorized symptoms of perimenopause, menopause, and postmenopause, I think there are a lot of amazing people talking about the typical ones like brain fog and all the things you mentioned, but women don't understand unless you've heard me. And I'm so glad now that your audience is going to hear that 80% of us will manifest musculoskeletal systems. And for 25% of us, they are devastating, not only in work, but in home. So what are the musculoskeletal symptoms? Well, number one is pain. I posted yesterday on my Instagram account that 71% of women in this 30 to 40 year span, the transition after we are no longer having children until we are really aged, have pain that's called arthralgia. Arthralgia simply means joint pain, general body pain. And sometimes we'll go to our doctors or even our orthopedic surgeons and have a variety of tests run, whether they're x-rays or MRIs, and no structural problem will be found. And sometimes you're told just to grow up and act your age, stop doing all that crazy stuff. Or sometimes you're told, well, there's nothing wrong with you. It's probably all in your head. I think that comes from a lack of knowledge and recognition within the healthcare system that 71% of women in this time frame will have arthralgia, which is joint pain without structural abnormality. Number one. Number two, we know that estrogen is critical for all tissues of the musculoskeletal system. It's critical for your bones. That's probably the most well-known example. We know, ladies, that when we were 30, that was our last opportunity to lay down great bone. So if any of you have daughters or younger sisters or friends in their 20s and 30s, you tell them that now is prime time. You need to really do what's important to bash your bones. So impact exercise plus smart nutrition. For those of us who are over 30, which is probably most of us in this audience, including myself, we can't forget that our bones are the structure of us, and that they're silent until they're not, until they are broken. You probably forget you have them. But fracture can be devastating in terms of pain. It can be devastating in terms of your function. And I'm just going to throw this out here now, is when women fall and break their hips, usually in their late 60s, 70s, and beyond, 50% of us do not return to pre-fall function, and a third of us die. So let's not do that. And do you know the number one predictor of future fracture? It's post-fracture. It's past fracture. If you have fallen and broken something, unless a bus hit you, and you've just fallen and broken, that is the number one predictor that you're going to do it again. So we got to figure out our bones. So estrogen. Number two, if you have risk factors for low bone density, a funny one I like people to notice is your mother shrinking? If your mother used to be 5'4", my mother used to be 5'4", and now my mother's down here on me, that's because her vertebrae are shrinking. If your own mother is shrinking, that means that in all likelihood, her bones are collapsing, and you are at risk for osteoporosis also. If you're fair, if you're female, if you had been a smoker in previous times in your life, those are all risk factors. Let's go get a DEXA scan. I don't care that in the United States, insurance will only pay for DEXA scans when you're 65. That is too late, ladies. You will lose 20% of your bone density between the onset of perimenopause and postmenopause. So you know what? It's a lot, and we might have to pay for it ourselves. We might have to not buy the $8, $10 expensive cups of coffee. At least that's what it is in this country. Save up that money and go get yourself a DEXA scan. It's worth knowing, right? So we talked about pain, we talked about bone. Did you know that estrogen is also critically important for building and maintaining lean muscle mass, which I'm sure we'll get to in more questions, because lean muscle mass, in my opinion, is the one thing. If you can only do one thing that you're going to do is build it. And finally, the forgotten musculoskeletal tissue that is dependent on estrogen is our cartilage. Our cartilage is the smoother than glass, smoother than ice end cap of all of our bones. This is my femur. This is the end of your femur. It's the end cap. What happens when estrogen walks out the door, slams the door behind her, and never comes back? The matrix, the structure of our cartilage weakens. So that's why if you Google around enough about arthritis and menopause, there's this entity called the arthritis of menopause. Well, it's not really arthritis of menopause. What it is once estrogen leaves, the cartilage matrix becomes weaker, and therefore the progression of arthritis in women is much faster than in men. So for all these reasons, if we simply allow estrogen to walk out the door without trying to do anything, whether it's nutritionally, building lean muscle mass, or evaluating hormone replacement therapy for yourself, you're just asking to be one of the 80% that suffers from musculoskeletal impairments with estrogen loss during menopause.
Wow. You mentioned a lot of things here that I would like to reiterate. I think are super important. The first thing that was kind of surprising is by the time you're in your 20s, that's when we are laying down sort of the foundation of our bones. So you mentioned, telling your daughters or your any females in your world who are in their 20s to please start doing impact exercise, right? That means sort of hit training or jumping up and down or running or any other kind of stuff that we can teach them in terms of building that bone density at that age.
Well, I want to say yes to that, but I want to take it back further. Listen, women, this is a generalization, but I'm just going to say it. Women do most of the childcare in the world. Our children will do anything they see us doing. If they see us eating poorly, that's what they're going to learn. If they see us moving around and exercising, and that's part of our home, they're going to learn that, right? So really bone building starts from the minute you're born, when our bones are mostly cartilage, but laying down of the best bone ends at about 30. So we have this time in our lives to get our bones right. And after that, we maintain bone, but we really don't build more. So in saying that, it's not just in our 20s. If you haven't focused on it in your 20s, if you're smoking like a chimney, if your nutrition is wanting, which happens, we've all been to university, right? Listen, it's time, as we're exiting our youth to really focus on bone, so that when you're living in prime time, which is I think 40 is an amazing decade and my 50s are the best yet, our bones come with us and don't betray us. I guess that was my message. We have a finite amount of time to build bone, and the rest of our lives to use bone as a storehouse of minerals.
So, okay, that's super important. The one other thing that was also very important was the consequence of a fracture or the consequence of not maintaining muscle mass and strong bone health. And what you mentioned, it falls and the consequence of that, and a third of did you say a third of the people who have fractures will actually die, and that's a pretty important statement. And that's what we learned in gerontology, because I've done my master's in gerontology, and we focused a lot on falls and fall prevention. And when I started it, I was like, why are we talking about falls? Like, do everybody falling all the time? But it is such a big deal that you can die. And that's because maybe sometimes we get infections with the operation, or sometimes we're just not recovering, and then you can fall into a depression, and then the depression, these other things. There's many reasons why you may die after that. So it is really, really important we don't even get there in the first place. So building that muscle and building that bone, please, just start right now. So the interesting thing that you mentioned as well is the cartilage, right? And how estrogen is helping keep that. And we can manage this with hormone therapy. We can manage it with exercise, nutrition, and all that, and not smoking and all these other things. So what happens then when it actually is gone? Can we actually regrow it back?
No. We cannot regrow cartilage. Bummer. But here's the deal. Since the beginning of my career in 1999, this is my beginning of my orthopedic career, amazing progress has been made in treating cartilage or treating frank arthritis. So when people come to me with arthritis, no matter what age they are, sometimes we have people with traumatic arthritis. Women have been in sports for now 50 years due to Title IX. Anybody can get arthritis, either traumatically, because you get one layer, you get one end cap. And if you have an ACL tear when you're a teenager, or if you lose your meniscus, or you get hit hard or fall off your bike, you can lose your cartilage at a young age. But what we're talking about is not only that, but the wear and tear of age, the wear and tear of repetitions, and estrogen. So what do? Well, I treat people in a whole person way, right? I am an orthopedic surgeon. I have all the tools I could show you if you want, all the putting metal in bones tools, but I start talking about unloading your joints. Joints bear 10 times body weight. So when I talk to you about building lean muscle mass and losing that 10 pounds of fat. It has nothing to do, people, with whether or not you fit into the same size that's hanging into your closet. It has nothing to do with going back to your high school reunion and looking like you did when you're 18. No, it has to do with unloading your joints, because let's just say you lose 1 pound, your joint perceives the loss of pressure of 7 to 10 pounds. So multiply that up. You lose 10 pounds, it's 100. You know, people who go through bariatric surgery and lose 100 pounds are losing 1,000 pounds of pressure, half a ton off their joints. So load is important. And I give people lots of tools for doing that. Number 2, we want lean muscle mass. Here it is again. I'm like a broken record. But instead of our joints pounding together like this, if we build muscle around them, our joints cushion and have less pressure on them. The next thing I talk about is smart nutrition and anti-inflammatory eating. Sugar will destroy your body on so many levels, but especially by creating huge inflammation, which also just adds to the deficit of estrogen. Estrogen in itself is an anti-inflammatory substance. Add on top of that, the sugar we eat in this country, Americans eat 16 pounds of added sugar if you choose to eat processed food. So in my patients with arthritis, we have whole conversations about anti-inflammatory eating.
Can I ask you a question about the nutrition and the sugar? See if we can define that, because we automatically think processed foods, a donut or a muffin or something baked good where you have sugar inside it. But what about the sugar that we eat from fruit, dried fruit, from a bagel that converts into glucose? Any those kinds of sugars affecting and are inflammatory as well?
So I am not against carbs. I mean, at one point in my life, I briefly did keto, but I am not, just experiment with it. I am not against carbs, but you have to be smart with your carbs. Fiber-filled carbs, vegetables are carbs, sweet potatoes are carbs, fibrous tissue are the carbs that we need. So when I say stop eating processed sugar, or I say we're going to eliminate simple carbs, any white carb, white rice, white bread, bagels, and I'll tell you what those do to me, because I know I track mine. Anything simple oatmeal. We want steel cut oatmeal because it's full of fiber, right? We want our body to work for our carbs. So when I talk about not eating sugar, that's what I'm talking about. Now, fruit is fructose. It's the most glycemic form of sugar we have. We have 2 kinds our body uses, fructose and sucrose. I am not against fruit, but I want you to treat it like dessert. It is not, and I never want you to drink juice again in your life. Juice,
Thank you.
500 calories of pure sugar. If you want fruit, eat the whole fruit, the apple, the orange, the guava, whatever. Eat the whole fruit. So that's what I mean by smart nutrition in an anti-inflammatory approach. So for arthritis, we talk about unloading, we talk about uninflaming. We can also do that with some supplements. We talk about building lean muscle mass. And then we finally get to the medically intervening things. Like I rarely use steroids for people with arthritis. It's just last 3 weeks. I don't like what it does to the body. I love using platelet-enriched plasma, which is drawing 60 cc's of whole blood out of your arm right here in this vein. We spin it in a centrifuge to isolate your platelets. Platelets are the part of your blood that when you get cut, they rush to the scene, they put a plug over the hole, and then you know what they do? They're not just sitting there plugging the hole, they burst. And they release all the growth factors that your body uses to start healing you. Well, we know now from good research that if we take 5 billion platelets and put them in the environment of arthritis, people can have significant pain relief for a year or more. So that I use that a lot for my people with arthritis. I also use cell matrix and the stem cells that live in that matrix from adipose tissue or fat, as well as bone marrow to treat arthritis and tendon problems. There's really good research with that. But here's the buyer beware. Anybody can buy the equipment to give you biologics and stem cells. I am going to encourage you to seek out care from healthcare professionals who have been respectful enough to you to get an actual education, because it is pretty poorly regulated around the world, and anybody can say they're giving you stem cells or biologics, and you need to get yours from board certified people, because that's the only way you know that they're educated enough and will exhibit safety standards for you. So those are,
yeah, an important message. Yeah.
it is an important message. And then finally, we get to metal, right? We can always treat arthritis with joint replacement, which is an incredibly successful set of procedures. But that is the spectrum of how I treat arthritis.
That's a big spectrum. And I wish my doctors who I've seen over the years would tell me the spectrum. So to give you a little background, people who follow, they know that I've been diagnosed with osteoarthritis, which sometimes I wonder, like, do I really have this or not? And I had a hip impingement after lifting a deadlift, and, you know, it just kind of spirals out of control. And so here I am, like 5 years later with osteoarthritis. I've seen 3 doctors in 3 different countries, and they're all like, surgery, that's it, total hip replacement. And I'm like, well, isn't there a spectrum? Like, before I get there, couldn't I just try a couple other things? No. So I always get a little bit nervous when somebody tells me these things. The one thing that really works for me is the PRP, the platelet rich plasma. And I was really excited about it, and it's helped me a lot. But I invited you to this podcast right after I heard you on another podcast, and you said something about, if any PRP doctor or doctor performing PRP is telling you that you're building your cartilage, is lying to you. If something like that. And I was shocked, because that's what my doctor told me. And I believed it. I mean, he was showing me a scan and saying, oh, you were like 0.2 and now you're 0.5 and now you're point, you know, I'll give you another injection and we'll try to reach like normal density of cartilage. So I'm like, wow, I can't believe. So now I'm I'm skeptical. What is going on? So is this what you're talking about? Some doctors just really not being transparent with you, and they're just, because I can't read a scan, I'm just going to believe, you know, what he's pointing out.
Well, number one, if you send me your x-rays, I will quantify your arthritis for you so that you know. So, and the kind of arthritis that you're pointing to, that is a result of a CAM impingement of the shape of your bones and the activities you put them through, is a different origin than many people with arthritis, because it has to do with the shape of your bones. But so let me give your doctor the benefit of the doubt. When I say, if anybody tells you that by putting in platelets, you're going to regrow cartilage, I think a few things. I think number one, they don't know themselves, which let's put that away. Let's assume they know. Number two, they realize that in a 15-minute doctor's visit, they are not going to be able to get into the deep science of stem cells and the 3 parts of regenerative medicine that it takes to regrow everything, and all the data. Maybe they just don't think they're going to be able to cover it adequately. So they know that most of the public, now you're probably different. You spend all your time in gerontology, but you know, what if the patient is an accountant and can, you know, solve world peace because they're a political person, but has no knowledge of the body? What are we going to say to them in 5 minutes that they'll understand what this is for? So if we give your doctor benefit of the doubt, maybe he was saying that because that's the most simple way to get people understand. Because here's the truth. We are currently not capable of regrowing cartilage by simply injecting something into the joint. If we want to regrow cartilage, it is actually a surgical procedure, because 3 things are needed to regrow a biologic system. We need a matrix, meaning a house for the cells to grow on. We need cells. preferably stem cells, right? Either from our bone marrow or from our fat. Every tissue has stem cells in it. And we need growth factors. Those three things in a certain order, right? Even if you inject all three things and it's all a jumbo, it is not that likely that we're going to lay down the very structured replacement for cartilage, because our bodies are complex and amazing. There's nothing chaotic at all. So just dumping something in a soup like goulash, it's like a vegetable soup, does not make a dish like lasagna, right? What you're describing, if it were true, if we could just dump anything in, you'd have soup. Cartilage is more like lasagna. It has layers in an order that must be recreated. So that's my explanation. I think you'll read anything on the internet about regrowing cartilage, but unless it involves those three components, I think what they're offering and what I'm offering when I put PRP in a joint is pain relief, is healthy environment. We know the growth factors that platelets relief will attract your body's own stem cells, and your body knows what to do, right? It now has the growth factors, it has the matrix of the original cartilage, and it's pulling in stem cells from your own body. That's why I use PRP. And the data shows that when you inject 5 billion, which is also another point, whoever's giving them to you must know how many platelets they're putting in it. Dose matters. If you take all those precautions, then you have a chance for great outcomes.
Wow. How do you know you get 5 billion in there? I mean,
we count them.
Oh, wow. That's a long time.
Yeah, we count them. So, people doing it in the right way, either our centrifuge counts them with light, or we take a little sample out of the part we're going to give you and put it in something called a Coulter counter and count it. If people are just randomly, that's like, I say, buyer beware. Go to somebody who actually knows orthobiologics and isn't just like buying the equipment and putting up their shingle because it's unregulated. It's critical.
That's probably why some countries don't even allow platelet-rich plasma injections, probably because of the just unregulated. But this are good questions that we should be asking our doctors about. And you mentioned the cell matrix, which is very interesting, and you describe the layers and how that works. But actually, how does that work? Is it a sort of operation? Is it something you inject with a needle? How do you do that?
It depends. For knees, for instance, we have a variety of matrix that can be used, a variety of commercial products. But again, every system, every biologic system it's like a house, has a foundation, which is the matrix. It has the cells, which are the people, and it has the growth factors that stimulate the environment to become a healing. So it depends what we're talking about. So if you're talking about your hip arthritis, I think the PRP you're getting is working in the ways that I've talked about. Pain relief, it's educating your own hip to take better care of itself. If you have any cartilage left at all, that's your matrix. If we were doing a knee and had a hole in the cartilage that we needed to fill, we would have a matrix layer, we would have a cell layer, we would put growth factors in the microenvironment. So
the way I understand it is that you can grow cartilage if you do the right
laboratory.
And so this is not like your own body regrowing, but you are creating the environment for it to grow. Is that correct?
Your body, well, it gets into a little bit of deep. I don't want you to get hate mail from other orthopedic surgeons. We can stimulate regrowth of cartilage, but not just by injecting stem cells randomly. Just a bottle of stem cells, you're not going to regrow cartilage or PRP. In the procedures we do to grow cartilage, it's a matrix, it's cells, it's growth factor. It's all three in one environment that we put together.
Okay, so then you have different procedures depending on the situation, but you
Exactly.
always have those three to try have the best outcome. So one question I get a lot is, what is the difference between PRP and stem cells and treat in terms of a treatment?
Well, let's go there. So platelets aren't cells at all. They're little sacs that contain growth factors, right? Platelets are a part of our blood. So that leads us to, what is a stem cell? Well, a stem cells by a definition are cells in our body that retain their ability to become anything, right? There are four kind of destinations of cells. And we're getting really kind of sciencey now, but you can have stem cells that can become anything you want them to do. Every tissue has them: muscle-derived stem cells, adipose stem cells. Certainly everybody knows of placental and blood stem cells. And they continue to be pluripotent their entire lives. That's the first destination of cells. Stem cells are then stimulated by their environment, by the place they live, by the growth factors they see to differentiate, meaning a stem cell can be anything, but they are stimulated then to become muscle tissue, to become fat tissue, to become heart tissue. That destination of cells are mature adult cells doing what they're designed to do. But what happens when those adult cells are done with their jobs? Nobody lives forever. Once you're done with your job, what's supposed to happen is your body is supposed to turn on the genes that lead to death, so that the cells simply die and are removed from the body. That's a process called apoptosis, or programmed cell death. Those are three very normal functions, but there's a fourth. Sometimes cells go bad. Sometimes they're supposed to turn off and they don't. And those kinds of cells are called senescent cells. The accumulation of senescent cells is one of the hallmarks of aging, right? So we need to do things like, and we're getting off track of your question, but to remove those senescent cells, I take Feisty to do that. But anyway, there are four destinations. Platelets are sacs of growth factors. Stem cells are the pluripotent cells that are capable of doing anything in your body, and we just need to learn to harvest them to heal ourselves. And having had a stem cell lab for many years at the University of Pittsburgh, and the great fortune of being in the lab of scientists like Fabrice Ambrosia and Johnny Heward, stem cell giants in this world, I believe that we have the power to heal ourselves, and we have not yet figured out how to do it completely. So stay tuned, but beware of the charlatans. But I do want to say, when all of these conservative things don't help us, and we say things like, I can't take this pain another day, or I have got to get my life back because I am slowly giving up everything I want to do, get a joint replacement. There is no need to drag yourself around and give up everything you love and gain 50 pounds from sitting around, because joint replacements are one of orthopedic surgery's most successful procedures. And so when done in the proper way by surgeons who know how to do it, in people who are motivated to do the hard work to get better, it's a completely amazing option and gives you your life back.
It's great that you said that. First of all, I'm glad you gave us a little lesson in biology, because the more we hear, we've heard some of these things before in the podcast with other people, the more it starts to sink in and absorb. And you're like, oh, hallmarks of aging. Oh, I heard that again. So thank you. And don't worry. This is an education for everybody. So the question that I'm wondering is, so we have, and I'm glad there is a time and a place for surgery for hip or knee or total joint replacement. But I like that there's a spectrum, and some people said, you know what, the doctor says surgery, jump right into it. Other people like me go, well, let me try a few things before, because I don't know if I trust this doctor, because is it just, surgery happy and they just want to make another 10 grand, or do they really, really need it? So I like that we have the spectrum, but the PRP I get, because I've done it. And I think I've done podcasts on that, but I haven't really done a podcast on stem cell therapy. So, but to me, it seems it's like next level, like it's more expensive, it's more invasive, and I don't,
More
I don't know if it
effective.
works. Is it more effective?
More effective. Yes, it
So
is.
what is the procedure like? I know that PRP is take your blood out of your arm, you spin in a centrifuge, re-inject it. It's a 15-minute procedure, you're out. What does a stem cell therapy situation look like?
Well, stem cells taken with its matrix, we use them from fat matrix. So we do a little bit, I get fat matrix and containing its stem cells from our flanks. I'm touching my own back of my hip where people tend to accumulate their love handles. That's all completely viable fat tissue we can use. So we do a little liposuction with a syringe, not a big plastic surgery setup, but we gather fat in its matrix. We purify it in the same room the patient's because this is done in the office many times. And we purify it. And then with the purified fat, taking out all the spindly connective tissue that gives us, what are those called? I've got them right now. Those, dimples in our legs. We take it all. That. We take out all the fibrous tissue that gives us that. And so we're left with pure stem cells, fat matrix. And then we inject that. So, it takes a little bit of time, not a tremendous amount of time, and can be done in the office. The other source of stem cells is actually bone marrow. All of our blood stem cells are made in our pelvis and our long bones. We usually get bone marrow derived or bone marrow matrix from, there's these places in our backs that are a little prominent, our crests, and we just put large needles in there after numbing up the skin and simply pull back because it's liquid inside of our pelvis, and we harvest those stem cells and we purify it and then inject those also.
Is that painful to
Well,
remove?
yes, it can be painful. The needles are large, but we use a lot of numbing medicine to numb the area. So afterwards, my first career in medicine was as a hematology nurse. I used to do a lot of bone marrow biopsies, and people tend to feel pressure and then afterwards have some aching, but it's not excruciating by any means.
And how long is that procedure when you have a client say get a knee stem cells for their knee issues?
Well, you know what? They should just plan on being in the office for at least an hour. It takes a minute to harvest and then to purify and then to re-inject, and there's no reason to hurry. So, they should just plan time for it. It's not an in and out 10-minute thing.
It's still quite quick, actually. If you could do it within an hour in one session, it's not like you have to go there, give your stem cells, and then come back after they're harvested. It sounds like you harvest them pretty quickly and then
in the
United
States, in the United States, you can't manipulate stem cells. You cannot, even if you take them in the operating room, you can't take them out of the operating room and put them in a lab. You have to use them right where they're taken. In this country, many countries outside the United States, you can manipulate stem cells, but not here. So that's why we do it this way here.
So what would you say then to somebody who's suffering with pain? We're talking about a woman going through the peri or postmenopause, and she's got joint pain somewhere. She sees a doctor says, get the surgery. Do you think that there are any questions she should ask? Should she try other things on the spectrum? Like, what would you do with your clients who come in with a situation like this? And I realize that could be like a whole different, everybody's a little bit different, but in general, what would the questions, how can we prepare ourselves for that appointment?
Are you talking about what procedure are we talking about? Because people come to me for a lot of reasons, right? So they come in pain and we go down the menopause estrogen pathway, or they come to me with a real injury and we work it up. I approach it the same way every time. What are the non-operative things that we can do? What are the physical therapy things we can do? When is surgery mandatory? Now I have in my, unless it's a traumatic fracture or something that I know based on my experience is just never going to get better without a surgical repair. then I always try the conservative things first. And I think it's fair to ask your surgeon, are there other things I can do that don't involve surgery? If you've gone to Dr. Google and have a bunch of suggestions, it's fair to ask those questions. And there are times when surgery is really the only answer. If you tear your rotator cuff, we can get rid of the pain, maybe with PRP and therapy.
Mm-hmm.
Sometimes we even inject steroids in there in people for whom we need to augment the repair. But here's the deal. Our musculoskeletal tissues, if we're talking about tendon and muscle, are like rubber bands. Once you tear a tendon or a ligament, it starts to retract. It lets go of its attachment, retracts. Cells don't jump. So you can calm the microenvironment as what we've been talking about, but you will never heal back the tendon to bone without surgically repairing it. And so if that's what we're talking about, if we're talking about a rotator cuff tear, I will try therapy, I will try PRP, but our literature shows that once someone is not sleeping because of the pain, then it's too far gone and you should repair it. And then you can augment with biologics if you want. I don't know if that answers your question, but surgery is sometimes the answer. I give my patients all the options that are non-surgical, but if I really know that that is their quickest pathway, I'm going to give them all the options, but I'm going to say, but to heal you, you need to have a surgical repair because it will not grow back itself.
Yeah.
So, yeah.
Yeah. And I guess everyone is super different. And if it gives any hope to anybody, I had a total ACL. That's my anterior cruciate ligament on my knee when I was 25. Never did the surgery because I did find a doctor who said, you know what, if you were a professional athlete, I'd do the surgery right now and get you on your way. He said, try physio first, physical therapy. That worked a lot and it helped me. And I've been able to do so many things and jump and run and do all this side to side movement, tennis, paddle, racquetball, all the things that you shouldn't be doing with a total tear. And I was pretty shocked. And oddly enough, I have no pain when I probably should in that area. And so, I know I always in the back of my head think, okay, well, maybe one day I will, because that's what the literature says. Once you have an injury, then you're probably more likely to have issues as you age. So quite question, like, should I have done it or not? I don't know, but so far so good. And that was PRP really
But
helped.
I think that all people are not like you. I've seen your picture. If that's your picture, jumping on the beach, not all people are like you. And it takes a tremendous commitment to lean muscle mass and really being strong to tolerate not having an ACL. So I don't want people to think that it's just easy, right? Because what's the point of an ACL? An ACL is to prevent arthritis. And our literature shows that without a meniscus and without an arthritis in 20 years, most people need a knee replacement. And so if they're committed like you are to being so strong, then yes, listen, I'm 56. I wouldn't get an ACL right now because I'm a straight ahead athlete. But if I wanted to ski again, if I wanted to play soccer at any level, then I would have to think twice. But it takes the kind of commitment that you've exhibited to lean muscle mass and being strong to live without some of these critical things. So I just didn't want to think anybody could get away with it. But it took a lot of work on your part to maintain, right?
Absolutely. And that's what drove me, even to this day, to continue to exercise and build muscle mass, because I was afraid of the surgery. I was like, I don't want it. If it takes this, I'll do it. And that's just me.
Wow.
And maybe most people wouldn't do that. And every time I fell back on my training and I wasn't doing the knee, training or building the muscle all around the knee, that's when I'd have a slip up. It would have so much pain, but it was more like
the giving way.
The giveaway. It was just, and every time if I get, then that would motivate me to get back on track. So yes, I think exercise and physical therapy, all that is just critical. I think whether you get a surgery or not, that's probably really, really important. So I'm wondering then, when somebody does need to get surgery, are there any pre and post steps that you'd recommend to your female patients in midlife who do actually need the surgery?
Well, in as much as you can prehab, meaning build lean muscle mass before a surgery, it's going to help you. We know from studies I've done actually that by doing the exercises you can do, even if you can't weight bear, there are still things you can do to be strong. That actually stimulates your muscle-derived stem cells and makes them more youthful and function better. So we prehab people. Number two, women are under-proteined. You've probably talked about this on other episodes, but I recommend my patients get healthy patients without the stress of surgery, 1 gram per lean pound, just in their regular diets. When we are recovering from surgery, I want them to get 1.5 or sometimes even 2, depending on how much energy and stress we're going to be using. And so those are, those are prehabilitative ways, pre-surgical ways to optimize with smart nutrition and getting as strong as we can before we go to surgery.
And then post-surgery, is there anything they should be doing or asking the doctors to make sure they are caring for them post-surgery?
Well, the same 2 things, right? We want to continue our smart eating and our high protein so that we can heal. If you're having orthopedic surgery, then we're going to get you in therapy rapidly after your surgery. But here's the deal. 2 things. Number one, you have to be as committed to getting better as we are committed to making you better, because I tell my patients that I say 50-50, and then I correct myself and say, okay, I'm going to do a great surgery on you, but you have to work hard like it's your job, because it's better for me not to do the surgery than for you to just lay around and get stiff. So because I'm a sports doctor, whether I'm doing a sports procedure or a total knee, I coach my patients. One of my patients says, don't be Dr. Wright's patient unless you want to take responsibility for your own health, because I'm going to push you to become your best self, just like I would an athlete. There is no room in my office for people who don't care about their own health and just want to lay around and get better, because you won't, right? So if you will be an equal partner with me, then I am the right doctor for you.
Do you think that's why some people who get surgery after surgery and they never seem to heal? Like, you would think, oh, well, once you decided to commit to the surgery, it's 100% sure you're going to be fine. Well, I mean, not 199%
Well, that's
sure.
not true, but
Yeah. Yeah.
true.
But there are a lot of people who don't. And that's why you get a bit nervous. Like, do I really need surgery? Is it going to really work? And then how long would it last? Your knee or your hip or shoulder replacement, whatever it is. Are they not getting better because they're not doing the work, or is it something else?
I think there are a lot of factors. If we just stick to hip and knee replacement, which is most of this conversation's been about, then, they are some of the most successful procedures in orthopedics. 97% of the time, people do amazingly. Total hips, and total knees. My total knees are outpatient. You walk out of the hospital in 2 hours, you're in your own home. Total hips do that, and then they're a month later, it's like nothing ever happened. People are like, why did I wait so long in pain? Total knees take about 3 months and lots of hard work, but sometimes people don't do well, because the implants weren't put in very well. Sometimes people don't do well because they are not willing to put in the work. It takes a lot of hard labor to recover. And then, okay, maybe there's the 3% that get a complication, or I don't know that bad luck ever has a meaning. So I think it's either, was it put in correctly, or did you do enough work? But here's what I would love people to stop doing, is reading in the grocery store what your possible surgery outcome will be, or taking a poll of everybody that lives in your neighborhood, because unless you are an identical twin, unless your body is the same, unless your motivation is the same, unless you have the same surgeon, you cannot compare how you're going to do with how other people are going to do, because you're not the same person. Now, what you can compare is your surgeon's outcomes. You could say to me legitimately, Dr. Vonda, what is the success rate of your ACL patients back to return to sport? Or you could say to me, of the last 20 patients you put total knees in, did they walk out of the hospital? Have they done well? Did they return to sport? So you can do that, and you can look at what's published in the literature. For most procedures, there is outcomes, general outcomes published. But, lots of people come to me and say, oh, Aunt Nancy and Sid, my neighbor, and all these people did poorly. I don't think you compare yourself with that unless you're identical people.
Good point. We do that though. We always compare.
You do that. I get it. We do it. Mm-hmm.
So we know, for example, PRP needs to be done every year, maybe 2. It's kind of this thing. It's not a, cure all, but I'm guessing, is the stem cell therapy similar, or is that, how do the outcomes for those? How long does that last?
Yeah, we have 2-year data, or we have longer data, but in general, we say this is going to probably have efficacy for 2 years.
Mm-hmm.
So, and then as the science progresses, maybe someday we'll say 5 years, or maybe you'll have to do this once. But right now we're saying for PRP 1 to 2 years, and the same for stem cells.
And then a hip or a knee replacement, does that last longer?
20 years. Yeah, 15 to 20 years.
And then they need to redo it, or how does
Not
that happen?
necessarily. You only redo it if it becomes painful, or people have tried to run marathons on their joints, which aren't meant to do that, and it wears down the pieces. So you only have to be revised if there's a need to do that. And so most total joint surgeons take yearly or every 2-year x-rays just to check on the implants.
One last question before we get into, I want to talk about your books, but have you heard of pentosan polysulfate for osteoarthritis?
No, I have not. You're welcome to educate me about it.
Oh, great. Okay. Well, I'll send you some material because this is evidently quite new. And I learned from Dr. Elizabeth Yorth. I'm not sure if you're familiar with her, Boulder Longevity Institute. Also into regenerative medicine, and an orthopedic surgeon like you. Actually, I'd love to connect you to. I think you'd have a lot to share. I'm going to start myself, so I'm going to be a guinea pig for everybody else to see how that works, and we'll see.
I'm writing it down.
Pentosan polysulfate, and the brand name is called Zilosul, Zilosul. Everybody can go, and maybe I'll put that in the show notes too as well. And we have a podcast. We not particularly just on pentosan polysulfate, but when I interviewed Dr. Yule, she mentioned that as an option. And then would love to hear your thoughts. So let's get into your books before we hit the questions for everybody else who's sitting here waiting to ask. You've got a book coming out, it's called Strong, the 4 Steps to Body, Brains, and Bliss.
Yeah.
And let us know a bit about that book, because that's coming out in June, isn't it?
It's coming out in June, and I'm looking around. I was writing part of it this morning. I was going to show you. So one of my books, my second book, is called Guide to Thrive, which is really a book that's made to help you build a strategic plan for your health, because we strategically plan everything, except we never strategically plan our health. Very few of us. So that was written to do that. And it was framed in a framework of 4 steps to build body, brains, and bliss. Strong, coming out in June, is kind of a sequel, because when I wrote that in 2008 or 2011, I was still suggesting lots of lean muscle mass. I'm surprised when I go back and read my own books, what I was suggesting is so in the media right now, when I was suggesting it 10 years ago. But what I was suggesting is body weight exercises and some high interval training. I am no longer suggesting that for women. My new book called Strong will, from a physical standpoint, focus on how to lift heavy, how to start lifting heavy, the way we should aerobically train, which is zone 2 base training, not with a few high intensity, but not high intensity every day. But the other thing that's become incredibly important to me in terms of being strong is having a strong mindset, because when I first wrote Fitness After 40 and Guide to Thrive, one of the things I said, encourage people to do, is to pivot and face your future. And in this book, we're going to talk a lot about mindset, on how to get into a place where you can actually optimize your future, face your future, because this is what happens. I hear it all the time. People are thinking about their future. They're terrified with fear about what it's going to be. And so what do? They look backwards at the past and they say, oh my gosh, remember when I was 20? And we remember what it was like to be then. And we remember all the good things and how strong we were and all blah, blah, blah. But I want to remind you that 20 was no cakewalk. 20, we were still in our parents' houses. We had no money. We didn't know what was good for us. We were probably ruining our brain cells on the weekends, right? So my contention is that we will never be able to have a strong mindset and pivot to the best of life if we're always looking over our shoulder. And so we're going to talk a lot in the book about how we're nobody's victim. We can figure out anything, whether it's being educated on a podcast like this or reading great books. There's a lot now out there. So it's not only body and physical brain, but it's the bliss of pivoting our mindset to not being facing the future out of fear, but really being a proactive part of our aging process. Because listen, I say this all the time. People want to live these natural lives, but what's more natural than aging? From the minute of conception, when you're two little cells, to the minute of our death, aging is the only consistent and natural thing we do. We just have to figure out how to do it better. So strong is all about strong mindset, strong body, and strong physical brain. And that's coming out in June, and I'll keep posting about it so people know where to find it. But it really is a sequel, an augment to the Guide to Thrive, to Fitness After 40, or even a book I wrote, which is an 8-week plan called Younger in 8 Weeks. So everything leads up to the continued conversation about how to be healthy, vital, active, joyful, and backed by the science that I do myself and that other people do.
I will have links to all of these in the show notes. I would love all those books, or at least a link to your website where you have the books. I'm so glad you mentioned that mindset, because as a gerontologist, we learned that the mindset is very, very powerful in aging and better aging. I don't know if you've heard of the research done by Becca Levy. She's a gerontologist. She's very, very famous for her research that she went all around the globe, talked to a lot of people, looked at a lot of data. And what she concluded was that those people who had a positive attitude towards aging, meaning, life is going to be great, I have the future, I have going to be do so many things, and instead of looking back like you did and having negative attitudes towards aging, those people with a positive attitude live 7.5 years longer. So it's worth.
Write a book? I think did she recently write a book?
Yes. She wrote a book called, I want to say The Age Code, or I can't remember exactly.
I have that book. Yes, I am familiar with her work. Yes, isn't that fascinating? It's how you view the future that creates it. So yes, exactly.
Yes, literally adding years to your life and life to your years. If you add life to your years, you're going to add more years to it. So I'm really glad you mentioned that piece. So before, I would love to ask everybody who's here, if you want to unmute, you can ask a question or comment. It would be nice to hear from you. Maybe Karen. Let's start with you. No? Oh, you have to unmute. You have to unmute. I can't hear you, Karen.
Okay.
Yay.
Dr. Wright is my
Hi,
doctor.
Karen. How are you?
Well, probably coming back to see you if things don't improve a little more, but 80% better than when I saw you, starting PT in a week. But I just came on this to glean, and I don't know if I have the right mindset. Maybe I shouldn't be thinking maybe the PT won't work, but I wanted to hear about the PRP. And, I definitely don't want surgery, but after having had that hip last year, I know that it can be a miracle when you need it.
It can. Yes,
So
it can.
I enjoyed it, and I'm looking forward. I'm going to get your book, so be sure and let us know when we can get it. The Strong.
Yeah, absolutely.
Okay.
Great. Oh, I'll be sharing that. Thank you, Karen. Lisa, do you have any questions before we let Dr. Vonda go? Oops.
I don't have any questions. Hi, doctor. Hi. I'm just here listening because One too that I need to get my body moving. To the point where I'm so achy. I have the hip pain, the knee pain, all of that, and everything. When I go get it checked, it's all great. They don't see any tears. Nothing is there, but nobody has ever, put that premenopause thing in my ear. And I'm just trying to just get a little information here and there to see if that's where I'm at.
Well, if you look very youthful, and if you are in your mid-40s, it's very likely that perimenopause is playing a part of it, even if you're younger than that, because our hormones start shifting tremendously when we're 35. And that's why women who are 35 become high risk for pregnancy, or prima gravida, which means old pregnant woman, right? Old. So even at 35 and beyond, our fluctuations in hormones become tremendous, and we can start having all the pain that you're talking about. So that's one thing to evaluate. Where are you in your menopause journey? Number two, as you're entering that and considering whether hormone replacement is for you, I recommend the book Estrogen Matters to everybody. It's by Carol Tavris and Avram Blooming. And it really has put together all the world's literature on estrogen replacement and the risks of various diseases, so that you can rest assured that there are relatively few risks, but every woman is different. So that's what I refer them to. And then if you haven't already started thinking about how you're eating, I mean, that's a very easy first place to start. Estrogen's a little bit harder to start, right? You got to go to a doctor, you got to understand the risks. But eating, and we talked a long time today about the devastating, life-changing role of sugar in our diets, and how paying attention to that and eating an anti-inflammatory diet can actually make huge changes. And it did for me. Actually, before I ever went on hormone replacement therapy, the first thing I did was eliminate simple carbs. I did a sugar detox, and I mean, hadn't formalized it. I now offer that to people, but I just stopped eating anything white and simple. And two things happened. My pain was dramatically less, and it was amazing, because normally I don't feel my body. I don't feel it now at my age. But when I did this, I was, 12 years ago. Number two, I lost 12 pounds without trying, because we eat 16 pounds of sugar a month. So without that, our body just loses weight. So those may be two easy places to start getting rid of this terrible pain that you're feeling.
Okay, I'll start that, because also, with the stomach issues too, and this and that. I'm trying to get myself back into the gym. It's like, exhaustion all the time.
Well, that is perimenopause, girlfriend. That is perimenopause.
Myself, I can't get from work. I just want to go straight home and just dive in the bed. I have no energy.
I know.
I'm
44.
Mm-hmm.
Yeah, you're in perimenopause. That's what this is. So all the things that we talk about in terms of anti-inflammation, thinking about your hormone levels and what you should do about that, forcing yourself to take a walk. You don't have to go do a big workout, just walk for 45 minutes. It'll make a huge difference for you, because what you're experiencing is real. You are not falling apart, and you are not going crazy. You are losing your estrogen.
Okay. Thank you so much.
You're welcome.
I would love that. And I think that's great information, great question, great answers. To add to that, Lisa, if it helps at all, I think the diet is actually surprisingly efficacious, just finding out the one that works for you in terms of anti-inflammatory, because I got to a point in February where I was waiting for this Pentacin to come, and I'm going to do a solo podcast on this. I think it's pretty interesting. And I suddenly could barely walk. And somebody, a nutritionist friend of mine, kept telling me, do the Dr. Gundry lectin-free diet. I was like, nah, and this is like a total free plug for him, but it actually worked within 24 hours. The pain was like 90% gone. I was shocked. I was like, I already eat an anti-inflammatory diet. I mean, if you know, but I hadn't taken out those lectins. And lectins are those toxins that plants make to protect themselves. And I eat a ton of these sort of nightshades and it's also in just like Dr. Vonda said, in some of these refined white carbohydrates as well. So take a look at that. I don't, it doesn't work for everybody. I've spoken to a lot of people who have similar issues. They've changed diets. Sometimes it works, sometimes it doesn't, but it's worth an exploration and see if that helps as well. And the other thing, you should have gotten to I had this program out, the Energy Reboot program for women going through menopause. So it would have been right up your alley. We just finished as a cohort, but I'll be coming out with that and rehashing it for people to just go on anytime they like, even without me. But I'll make sure I get that to you, because it sounds like, yeah, you need it. And just like Dr. Vonda says, probably, yeah, going through perimenopause.
Thank you.
Excellent. Okay, great. Well, I'm going to have to let you go, Dr. Vonda. I will have links, the best place, actually maybe let you explain where's the best place to find you, and I'll have links to all of them.
So you can find several parts of my life on my website at drvondawright.com. I am on Instagram at drvondawright.com. So you can find most of what you need there. Also, I've actually just launched a advanced menopause support supplement line for women. There are 3 products actually. The first one contains all the micronutrients we need to support us. I mean, I'm not perfect. My diet's not perfect. I try my best, but I still need micronutrients. It contains augmentins and a proprietary rhubarb extract that works on the estrogen B receptors to help relieve some of the symptoms of menopause. The second supplement is focused on energy. It contains 300 milligrams of NMN, which is a precursor to NAD+, which is the energy supply for 400 different chemical equations in our body. So I take that and it makes me feel amazing. And then we have a prebiotic, a probiotic, just trying to support this time in life, because nobody eats perfectly.
Great. Actually, we should do a podcast just on supplements for women going through menopause. I see a new one coming out, because I have all these questions about supplements, and we just have run out of time. So let's book that. I think everybody would love to know a little bit more about that. Thank you so much, Dr. Vonda, for all that you've given us. Such great information, useful tools. Do you have any last words for a woman going through peri or post-menopause?
I have a couple last words for women going through this amazing time of life. It's amazing to be in our 40s, 50s, 60s, and beyond. But here's what I want you to remember. Number one, very practically, what I just said is what you're experiencing is real, even if no one around you is talking about it. You are not falling apart, and you are not crazy. But what you need to do is be a student of your age and really seek out the answers, because here's also the truth. You are worth the daily investment in your health and the time it takes to feel amazing again. I know you have millions of people to take care of, but take care of yourself, because you are worth it.
Great advice. Thank you so much. Have a wonderful day back in Florida. And everybody else, yeah, have a good day, good night, good morning, wherever you're at. And we'll see you next time for part 2 on supplements.
All right. Farewell now.